Okay, guys, so if there's anybody watching this video who is not in my class, I'm creating this presentation for the inimitable Dr. Garvin's class at TSU. One element of this assignment that we're given is that we're to create a toolkit, and you'll see my so-called toolbox or toolkit at closer to the end of the presentation. Just so you know, that doesn't have anything specifically to do with the intervention that I'm presenting on, prolonged exposure. It's just a part of the assignment. So we're just going to get started with a little video, and I will say more after that.
I must have crumbled to the ground a few seconds after I hit the ground.
It took 8 weeks to recover from the severe bruises on her feet and fractures in her legs, but the real pain was only beginning.
I basically had no life. That's the way I felt. And at a point in time, I cried and told myself, why did you jump out of that window and save your life if this is how you're going to live? You have no life.
Sherry moved out of the home where she was raped, but the attack still haunted her. Everyday activities became impossible. She never knew what would trigger the memory.
You were desperate for help, basically. Right. I realized he came here to rape me.
When traditional rape counseling didn't help, Sherry turned to Dr. Edna Foa, a renowned psychologist who discovered that women who survive rape suffer just like soldiers who survive war.
What made you think that rape victims and combat veterans suffered the same kinds of
The symptoms are the same symptoms.
Symptoms like flashbacks, nightmares, anxiety. In fact, Foa estimates that half of all rape victims are suffering from post-traumatic stress disorder 3 months after the attack, and 1 in 7 are still suffering years later.
Who are the rape victims that get it?
We think that the ones that are pushing it away, the ones that don't talk about it.
It's moving toward me, and I jumped.
All right, so she says some interesting things there. Dr. Edna Foa, who developed prolonged exposure therapy, I want to point out, she mentions that rape victims suffer from a lot of the same PTSD symptoms as war veterans. Keep in mind, PTSD did not always exist as a diagnostic category or diagnostic label in the DSM. I think it came out in the early 80s, maybe 1980 or so. But it was that label, that diagnostic category was developed by Dr. Bessel van der Kolk. And before then, you had war veterans coming home diagnosed with things ranging from major depressive disorder to psychosis, schizophrenia, anxiety disorders, alcoholism, all kinds of things. And the problem, and some frequently they were comorbid, so you had a lot of different diagnoses running around. The thing he observed was that first-line treatments for any of those things tended not to work with these war veterans who were coming home, and so he felt that the actual underlying pathology was being shoehorned into these pre-existing diagnostic labels, and he was very much correct about that. I just think that Dr. Foa's research is a really good kind of part 2 to that work, which initially was they were more focused on the men that were coming back from war. And this is where we're talking about women who are dealing with rape trauma, having PTSD symptoms. So in the Dateline interview that we just saw, if you watch the whole thing, and there's a link at the back end of this presentation, they conflate flooding and prolonged exposure, and that is quite inaccurate. So it's a good episode to watch in many ways, but they're not psychologists, so they got that one wrong. Flooding and prolonged exposure are quite different. They're both related to exposure therapy. She also mentions that the rape trauma survivors who tend to do the worst and have PTSD symptoms and have the hardest time shaking those symptoms are those who are pushing it away, as she says. Okay, so that is to do with really her theoretical basis for the intervention that she's developed, because the theory that she's basing this on is the idea that actually the avoidance behavior of the traumatizing stimulus, circumstances, emotions, thoughts, memories, all of that stuff. We'll just call it the traumatizing events, or the traumata. We'll just for shorthand call it that way. Those who are turning away from the traumata, who are avoiding it, that actually perpetuates the difficulty. And so, prolonged exposure therapy is intended to get you to turn towards and engage with the traumata. So yeah, I'm Facey Cross, and this is on prolonged exposure. It is a behavioral therapy for PTSD, was developed for rape trauma survivors, as mentioned. It also has some cognitive components, so you could say it's a cognitive behavioral therapy. It is highly structured compared to a lot of other therapies and compared to a lot of exposure therapies, although exposure therapies are somewhat structured anyway. Typically, they run from 8 to 15 weeks, 90-minute sessions. It involves imaginal and in vivo exposure. Imaginal, as you might guess, involves using your imagination to turn towards the traumata. So, for instance, you might record yourself describing the traumatic experience in detail, and then that can be very difficult. And then later you will listen to yourself go through that to help you get more exposures, imaginal exposure to the trauma, until you basically have trained your brain that these things can be thought about without being relived, and that you are now safe in the present time. In vivo is more like in life. It literally means in life. So you might go to a dark alley that's similar to the circumstances in which you were once assaulted, or you might at first think about doing that. And so, but it's essentially, exposing you in real life. And again, it's all directed towards getting you to turn against the avoidance behavior, which is maintaining the symptoms. Now, the book that she was the principal author of, Prolonged Exposure Therapy for PTSD, is the official treatment manual. Also, PE involves the exposure hierarchy, which comes from the systematic desensitization. Here is an example of what the exposure hierarchy looks like. If you were going to use it to prepare yourself for a presentation you have to give when you're afraid of public speaking. So at the bottom, we see identify topic for presentation. In the middle, we see maybe record yourself doing a video of the presentation and observe yourself. And so that's going to be more anxiety inducing than just identifying the topic, but less anxiety inducing than the actual final presentation. At the top of the pyramid is the actual presentation that you're going to give. Now, I had this AI image generated. It actually depicts, not me and my son, but my son is half Asian and depicts like, a similar situation. But I actually helped him out with his fear of heights. He wouldn't say that he completely kicked his fear of heights, but it's substantially behind him. Day one, this is just simple exposure theory or exposure therapy that I work with him on consensually and therapeutically and gently. And on day one, he's like having a hard time getting to rung 2. By the end of the week, he was at the top of the roof. So quite a turnaround. So I would say, and he would say, he doesn't have exactly a phobia, that he's still nervous about heights, but substantially he's conquered a lot of his fear. So that's exposure therapy in its most elemental form, using it to deal with your fear of heights. It's a behavioral intervention, and prolonged exposure, by comparison, it is also an exposure therapy, but there were some differences. And we've talked about some of them. Some of the key differences are that it is prolonged, as the name suggests. It is, highly structured compared to some of the exposure therapies, and it's intended to help clients process traumatic memories and reduce PTSD symptoms by decreasing avoidance. A word about Edna Foa and her professional and academic background. She focused on anxiety disorders and PTSD. She developed PE for rape survivors. She's an Israeli professor and is renowned internationally as an authority in psychopathology, anxiety, and PTSD. So it is evidence-based. It has strong research support for efficacy as well as effectiveness, which is to say that it works both in experimental conditions, and also research in the field shows that it actually works in the real world with a variety of clients that have appropriately similar situations that they're dealing with in terms of psychiatric distress. So it's very exciting because rape trauma is difficult to treat and PTSD is difficult to treat. And so it's good to have a therapy that works well for it. And this does. Research has found that it significantly reduces PTSD symptoms, but keep in mind, rape trauma survivors can have other symptoms that are not purely PTSD symptoms. So it doesn't do everything, but it is an important intervention. Broadly, it's among the most effective PTSD therapies. It's proven effective for various traumas and anxiety types, and has long-term benefits. So just like my son with the ladder, the benefits are long-term. It's not like perfect. And if we did a follow-up exposure therapy with the ladder, it would probably help him even more. So this gives you an idea that you do it once and basically you've likely made substantial progress that is permanent. And it's widely recognized as efficacious for relevant psychiatric disorders and circumstances. Pros and cons. We've gone over some of the pros, but we want to compare to the cons, right? So high efficacy rate, symptom and distress reduction. So think about subjective distress reduction, okay? Insight is not required, which helps its external validity because you can use it for a wide variety of clients who have PTSD. It's procedurally straightforward. That makes it easier for clients to actually work with this in terms of they're able to do it. It's not easy, but it's something that is something they can do. And it's also good for practitioners who are able to understand how to learn to use it. It doesn't require tremendous amount of training. Client retention is high compared to some other interventions, for example, compared to flooding, which we mentioned at the beginning, right? So flooding can overwhelm PTSD sufferers in particular, so they'll have a hard time like staying with the therapy, okay? and ultimately, if client retention is higher, that helps your efficacy and effectiveness levels. On the other hand, like actual client retention is one of the cons at the same time, because of course, compared to some therapies like EMDR, for example, EMDR has lower dropout rates than PE has. Okay, so EMDR is very different. It's not exposure therapy based, but EMDR isn't appropriate for everybody and may not work for everybody. And similarly, prolonged exposure may not work for everybody and isn't appropriate for everybody. So insight is not de-emphasized. That can be a downside. It's not required, but it's also not emphasized. But of course, you can always back it up with some other therapy that might be insight based. Okay. Yeah, so it is not intended for a broad range of symptoms of PTSD. So it doesn't like fix everything related to PTSD, and especially not everything related to trauma. Initial discomfort and symptom exacerbation is commonly part of the process. So it's going to be difficult when you think about it, since the theoretical basis is you're turning towards the traumata. So that's going to be an uncomfortable experience for most people. Its counterindications include imminent suicidal or homicidal behavior, unmanaged psychotic symptoms, and active and severe substance abuse. So if you have some of those things going on, you may want to augment, take precautions with respect to, or deal with those to a certain degree before you get into using PE. Patient avoidance and resistance behaviors can be a problem with this, because once again, you are deliberately subjecting somebody to situations and therapies that are uncomfortable as a necessary aspect of the healing process. You might think of this as like how it's necessary to break the bone and also to handle the leg in order to do the imaging, say, and as a part of the process of getting your leg mended once you have gotten a broken leg. So there's pain involved, and you can imagine there's resistance at times. Okay. So cultural considerations, right? So when you're talking about a very vulnerable population like rape trauma survivors, they may feel an increased need for familiarity and comfort. And so if you're dealing with somebody who's not the same sex, counselor that's not the same sex as the client, for instance, or the same race, especially sex, but and even the same race or different, not the same background as them in some way, it could be meaning that you'll have extra challenges with rapport building and trust development. Okay, so that's something to be aware of. Don't assume though that that's going to be a problem, because it's often not. Just be aware and kind of have your rear view mirror out that that this may be something to look for. Key takeaways: it is evidence-based, very much so. There's good evidence for it. It effectively addresses PTSD symptoms, which I'm excited about because PTSD is a tough one to work with, and helps process trauma and reduces avoidance behavior. Here's our toolbox. Okay, we've got spinach, telephone, ladder, a bunny rabbit named Fiverr, a temperature gauge, or we could say thermometer, same thing, and a stopwatch or a timepiece. So the spinach represents the cognitive aspect of PE, right? And we might bring the spinach can out to help us signal changing gears to psychoeducation. Psychoeducation also can help us build rapport and a therapeutic alliance. Okay, when the client feels they are increasing in their understanding, and they can see that we do understand some aspects of what they're going through, maybe talking about the neurochemical dimensions of PTSD, which are fascinating and illuminating. That can actually help build rapport, because I feel like they're in good hands, and also that they're getting in their understanding of what they're dealing with. It can assuage thought errors. So a lot of this cognitive stuff and psychoed can help us avoid blaming ourselves or looking down on ourselves for loss of function, or for feeling terrified in mundane pedestrian situations. Getting psychoed and cognitive elements can also help to engage the higher brain functions, which can be a relief if somebody's feeling some overwhelm. So the telephone signals that it's time to communicate or to get heard, right? So we can bring it out because we want the counselor to really hear us. Okay, so you can just kind of bring out the telephone or the telephone handle and say, hey, shut up for a minute, I'd like to be heard. You can bring it out as a reminder to yourself that you want to pay more attention to your quieter feelings, or that the counselor needs to hear you without censorship or judgment. You can also bring it out to suggest that you are searching for your voice, or that you're going to use your voice. Okay, so that's an important milestone that clients need to try to reach. The ladder, well, this is a little bit like the pyramid we talked about earlier. How far have you come? Well, we can use a ladder to kind of measure that. We can take a look at how far we have to go, right? And so you can look at your relative position on the ladder. We can bring it because we're saying, hey, it's time to climb now, let's get serious. And we can depict the exposure hierarchy as a ladder, rather than as a pyramid. And I would suggest, you could actually have a picture of a ladder in the office that you bring out, and you can indicate the relative progress that we've made. The thermometer, okay, so here, like I would bring, like kind of pull together thoughts from the class, but we're not in a class, this is a recording, and say, what could we use the thermometer for, right? So, well, let's see. So we could use it as an indication that we're trying to learn, have we gotten warmed up yet, right? So are we feeling engaged? Feeling warm enough? In other words, comfortable. Are we too hot? Okay, so are we feeling like overly stimulated, aroused, dysregulated, or overwhelmed? Or are we too cold? In other words, are we withdrawn, or are we disengaged and we're not really, connecting? Maybe we feel isolated. So do you need to cool down, right? So maybe help us feel more comfortable and regulated. And do we need more time to warm up before we increase the intensity? So these are things that can be indicated there. We have the bunny Fiverr. That's a name of my childhood bunny, Rabbit, my real bunny Rabbit. And he can be brought out to suggest that we need help regulating, or that we were just wanting to check in with our soft, vulnerable parts and feelings. We may need to take off some of our armor and check in with our gentle, compassionate, timid side. Like maybe point out that, okay, we've got a lot of anger happening and such, and maybe we also want to check in with the other things that you might be feeling. So finally, we have the timepiece, right? And the timepiece can be brought out just to remind us that this is going to take time. So if we're feeling frustrated or a lack of confidence about where we're at, just remember that time is a factor. So no matter how hard we try, like there's a certain amount of time that needs to happen. If we're feeling upset or fearful, we can bring out the stopwatch and sort of click it and say, hey, let's just take a pause. Let's just take 5 minutes or 10 minutes, and let's do nothing or sit quietly, or just relax a little bit so that we can summon our energy and courage. And so that is my presentation. You can reach this presentation at the indicated bit.ly URL. There's a QR code that you can you flash your phone toward, and that Dateline video is also at the presentation on this page. You can click on that and get there. So thank you for your time. This has been Prolonged Exposure.